Hello, this is Dr. Bratzler. I'm going to record the presentation for week 11, which focuses on health insurance and healthcare systems. This is textbook chapter number 11. If you look at the syllabus for the semester, you'll notice that for weeks 11, 12, and 13, we're all focused on chapter 11. Dr. Raskob and I met, and I will do all three of the presentations. My plan currently is to do two sessions today, and then I'll record a second session for the last half of chapter 11. And then next week on Monday, I will have a Zoom open mic if any of the students would like to call in and ask questions about chapter 11. I think I can cover all of the content in two of the sessions, and then again we can have a open discussion via Zoom next week if you have any questions that you would like to ask. So let me go through the presentation for the first half of chapter 11. These are the learning objectives that I'm planning to cover today. They include talking about the largest of the government health insurance systems. I'm then going to describe employer-based health insurance, making sure that you understand the differences between fee-for-service payment and other models of payment such as capitation. We're going to spend a little bit of time talking about the consequences of both underinsurance and uninsurance, and then in the next lecture that I record, I will focus explicitly on some of the consequences that we've seen in the United States of rising healthcare costs. We'll talk about U.S. healthcare expenditures, trends and projections for cost of care, and then I'm going to describe some of the payment models that have been developed going forward to rein in healthcare spending. So I'm going to start off my presentation today by telling you about a patient couple that I take care of at one of the clinics for the uninsured. In the next session, I'll bring this case forward as a point of discussion. But I recently saw a couple that have been married for many years. They immigrated to Oklahoma from Mexico more than 20 years ago. They both work full-time doing custodial services. However, both of them are uninsured. They work for employers that don't provide health insurance. Olivia was referred to me because of uncontrolled diabetes. Her hemoglobin A1C, which is a test that tells you whether or not a person's diabetes is under control or not, was greater than 10. Normal is less than about 6. She had very early diabetic kidney disease. She has hypertension. Her husband, Jesus, was recently hospitalized with a small stroke and still has some residual weakness of his left hand. He also has high blood pressure and high lipids in his blood. I want you to remember this case because I will tell you more about this particular couple and tie it into this context of discussion of health insurance next week in the next presentation that I record. So this is what's in your textbook. Healthcare expenditures in the United States currently exceed $3 trillion per year, which is almost 18% of the gross domestic product. That means for every single dollar that the U.S. economy produces, 18% is spent on healthcare, more than $9,000 for every person in the United States. And one of the sad things about healthcare and healthcare costs is that healthcare expenditures have been higher than the rate of inflation for more than 40 years now. Well, this is a little more up-to-date information than was in your textbook. This is all data from 2018. It comes from the Centers for Medicare and Medicaid Services. Their actuarials produce this report annually. In 2018, healthcare expenditures grew 4.6%. Again, that's higher than the rate of inflation. In 2018, as a country, we spent $3.6 trillion, which was $11,172 for every single person in the United States, and was, again, very close to 18% of the gross domestic product. But when you look by payer type, that we're going to talk about in just a moment, Medicare expenditures grew 6.4%, Medicaid grew 3%, private health insurance costs grew 5.8%, and something I'll talk about in our next session is out-of-pocket spending, which grew 2.8% in 2018. I'm going to particularly highlight out-of-pocket spending because this is an area that is causing great problems for anybody, even with those who have good health insurance. Well, where do we spend all that money? $3.6 trillion. Where do we spend it? Well, we spend about $1.2 trillion of that on hospitals. That went up 4.5%. From 2017 to 2018. Interestingly, healthcare services in hospitals is actually going down, but we're spending more money on hospitals, and that's because prices are going up. We spent about $725 billion on physicians and clinical services, which was a 4.1% increase. Retail prescription drug spending, $335 billion, which was a 2.5% increase. Again, these expenses are very, very high. So we're spending a ton of money on healthcare, $3.6 trillion. We're getting great health outcomes, right? Well, sadly, no. This is the actual growth of spending. And again, you've probably seen graphics like this before, but it shows that the United States spent more as a percentage of gross domestic product than any other industrialized nation in the world. Our rate of spending is very, very high, almost twice as much as most of the other industrialized nations to which we are compared. And at the same time that we spend all of that money, we're not getting great health outcomes. So this is a complicated graphic. The green line shows the United States, and what it shows you is that our healthcare expenditures have grown substantially, but our life expectancy is less than most of those other countries that we're often compared to. So we're not getting the best bang for the money that we're spending. We spend a lot of money on healthcare, but we don't have the best health outcomes. And in fact, if you look at the life expectancy at birth among comparable countries, you can see Japan has the highest life expectancy at 84.2 years, and the United States is at the bottom at just over 79 years of expected life expectancy at birth. So our life expectancy is lower than these other industrialized nations, and the large amount of money that we're spending on healthcare isn't giving us the great outcomes that we hope for. So how do we pay for healthcare in this country? So now we'll get into the meat that's in chapter 11 of your textbook, and we'll talk about some of these issues on payment for healthcare. So one of the first ways is government-supported health insurance, which has become one of the largest programs for health coverage in the United States. These two programs, Medicare and Medicaid, actually account for 25% of the federal budget. 25% of the entire government's dollars are spent on Medicare and Medicaid. Medicare, so let's talk a little bit about Medicare. Medicare typically, when it was first introduced in the 1960s, covered persons who were 65 years of age and older. This was the retirement and still is the retirement age. And so healthcare coverage for Medicare patients started when they retired or when they were eligible for retirement at age 65. The program was expanded to cover disabled persons eligible for Social Security. It also covers patients with end-stage renal disease or kidney failure, particularly those on dialysis. And remember, there are different types of Medicare. There's Medicare Part A, which covers hospital care, skilled nursing facilities, and home health care after a patient's been in the hospital. Medicare Part B, I'll talk about in a moment, is a subscription program that pays for physician care, emergency department care, and other outpatient services such as imaging, radiology, and things like that. Medicare Advantage is part of Medicare Part C. These are prepaid health plans that are provided by private insurance companies. Medicare pays each of these private insurance companies a set amount of money per patient, depending on the patient's overall severity of illness. And then lastly, the prescription drug coverage plan, or Medicare Part D, which covers most medications. One thing to remember about Medicare is that it does not pay for nursing home care. Most nursing home care in the United States is paid for by the Medicaid program, not Medicare. So let's just talk about each of the types, the parts of Medicare. Part A, it's paid for by the payroll tax. If you've ever had a job, if you look, one of the things that comes out of your paycheck every month is the Medicare payroll tax that's deducted from your paycheck. That's how we pay for Medicare Part A, which is the biggest chunk of spending in the Medicare program. It's important to remember that because it turns out in the United States that most people, even with all of the years that they pay into the Medicare program, don't pay enough to cover their total cost of care once they go on Medicare. Also, since the number of elderly are increasing and we have fewer young people that are paying the payroll tax, the Medicare is in deficit spending most years now. There's no out-of-pocket premium for Medicare Part A, but there is an annual deductible, and the largest expenditures are for hospital care, as mentioned. Medicare Part B is voluntary. You have to sign up. You have to actually enroll in it. You don't have to get Medicare Part B, but most Medicare enrollees do. It pays for outpatient services. It covers the cost of going to see the physician. So if you're in the hospital, Medicare Part A will pay, but for the physician charges or other outpatient charges, you need to have Medicare Part B. It's funded by general tax revenues, about 75%, and then monthly premiums. I see that's misspelled, but you have to pay a premium for Medicare Part B. It does have co-payments of up to 20% and a $150 deductible per year. There are many, many private insurance plans that now provide what are called Medigap policies to cover the cost of those co-payments, because when you think about it, a 20% co-payment on some hospital bills or others could be a lot of money. So many people who can afford it purchase Medigap policies to cover the co-payments. Medicare Part C is also known as Medicare Advantage. There are many private plans such as United Healthcare, Humana, Blue Cross Blue Shield that run through Medicare and by law must provide services that are equivalent to regular Part A and Part B Medicare coverage. So if you sign up for a Medicare Advantage plan, you'll often pay a premium. However, you get all of the services of Medicare Part A and Part B, and many of these Medicare Advantage plans also cover some of the expenses of Medicare Part D, the prescription drug programs. And then Medicare Part D is the prescription drug program. You have to be enrolled in both Medicare Part A and B to be eligible. There is a monthly premium and an annual deductible. There is what's called the donut hole that's slowly going away, but if you reach a catastrophic level of drug cost, if you have extremely high drug costs, for instance, you're a chemotherapy patient or others, Medicare will pay 95% of the additional cost of all of those drugs once you hit that catastrophic level of spending on Medicare. So this is a simple graphic that gives you the 4 types of Medicare coverage: Part A, hospital insurance; Part B, medical insurance, particularly for outpatient services; Medicare C or Medicare Advantage plans; and then prescription drug coverage, which is Medicare Part D. Let's move to the Medicaid program, which provides a lot of the coverage for healthcare in the United States. In fact, probably spends as much or maybe more than Medicare now. It's a federal state program. The federal government pays the largest chunk of the fees for the state. It pays for care for the poor, children, and particularly pregnant women. Right now in the United States, Medicaid pays for 50% of all births in the United States and pays the health care cost for 40% of the children in the United States. The other thing, as I mentioned earlier, Medicare does not pay for nursing home care. Medicaid does, And currently, once you can no longer afford to pay for nursing home care, in other words, you've spent down your life savings, then you often have to enroll in Medicaid, and Medicaid covers the cost of nursing home care. The funds come from the federal government, depending on the per capita income in the state. In other words, there's a state matching formula that's calculated, and it's based on the per capita income of the residents of the state, and the federal government will pay anywhere from 50 to 83% of the Medicaid expenditures for that state. The state has to pick up the rest of the cost. If a state decides to accept basic Medicaid, which all states have, then they must provide coverage for disabled, children, and pregnant women that are below the federal poverty limit. So once a state signs on, there are certain services that they must provide. There is some state flexibility. For instance, things like medications, eyeglasses, some state Medicaid programs will provide some transportation services. It's optional, and you can get some federal matching funds if you do provide those services, but the state again has to put up part of the money to do that. So there is some state flexibility. One thing to remember about Medicaid is the fact that nursing home residents, though they represent only 10% of the total number of people who actually are on Medicaid, they're very high cost, and they probably spend as much as all the other programs under Medicaid just to pay for the nursing home care. And then one of the specific programs under Medicaid is the Child Health Insurance Program, or CHIP. And the nice thing about CHIP is it raises income limits for eligibility. So the poor at even higher levels of the federal poverty limit can be eligible, and it provides a lot of health care for children in the United States. It's paid for by general tax revenues, state matching, and also some tobacco taxes. So that's the government programs. What about employment-based health insurance? Why did we get there? Well, during World War II, employers were not allowed to raise wages. So, in lieu of paying more salary, since they couldn't do that, they started offering healthcare benefits. And as that grew, insurance companies were formed that an employer could simply pay the insurance company to provide those health benefits to their employees. When the programs were first set up, the insurance companies usually set the premiums or the amount that they charge for the health insurance based on the community rating. In other words, everybody in the community got the same premium based on the overall healthcare cost of the entire community. However, over time, some employers realized that their patients, their population of employees, were much healthier than other people in the community, and so most health insurance plans moved to a program of experience rating, where they look at the overall healthcare cost of the employees in that group, and they use those to set the premiums. So in other words, if you're a company that has a very healthy workforce and you have lower overall healthcare cost historically experience in your population of employees, then you'll see lower premiums than some other company that may have a population of older or patients that have higher costs for health care. Now, there are multiple different payment models. The one that's been most prevalent for a long time is the fee-for-service system. Certainly when I first started my practice, everything was paid for by fee-for-service, where basically an insurance company would set a payment for a service based on something called the, quote, customary, prevailing, and reasonable criteria. So they would look at the community, they would look at what the prevailing payment was and what seemed to be reasonable for the service, and that's how much they would pay you. But as a clinician, when I was a physician in early practice, the more things that I did, the more patients I saw, the more procedures I did, the more patients I took care of in the hospital, the more tests I ordered, essentially I could get paid more for doing more. So the fee-for-service model of payment has been described as inflationary, since providers typically have had absolutely no incentive to hold down costs. So it's sometimes fee-for-service is also called volume-based payment. In other words, the more you do, the more you get paid. But it's been described as inflationary because it doesn't hold you accountable for the overall quality of care or the cost of care, and because it rewards more care, regardless of whether the patient actually needed it or not. So as a licensed physician, I can order, if I'm in my ambulatory practice, can order virtually any test or procedure I want, regardless of whether or not it's going to benefit the patient. Now, it's not ethical, but there are plenty of examples of things that happen all the time in healthcare that don't change the course of treatment for the patient, aren't going to make things any better for the patient, and yet if you do them, you get paid more. The important thing to remember in my field of health quality is that when you do unnecessary tests, you order more things for a patient. We know for a fact that sometimes that results in harm. For example, if you do too many x-rays, you're going to find eventually some lesion that you think needs to be biopsied that often may be just a benign incidental finding. The other thing is if you do more tests, you're bound to have false positive or false negative tests, which could potentially result in patient harm. So that's one of the big challenges of the fee-for-service payment. The more you do, the more you get paid, but there's nothing holding you accountable for the quality or the necessity of that care. And there are great examples. Here's one of them. This is an article that was published a few years ago that looked at doctors who own their own stress test technology. So if you have a patient with heart disease and you want to test and see whether their heart can tolerate exercise, things like that, you can do these nuclear stress test machines in the office or in a clinic. And this particular study in the Journal of the American Medical Association found that physicians who owned the equipment ordered tests in 10% of their patients versus only 4% of the time, 4.3% of the time, for those doctors who didn't own the machines. In other words, the doctors were paying for the machines by doing more tests and generating more income. Similarly, here's one of my favorite examples. This is a cardiac catheterization lab in Elyria, Ohio. This was published in 2006 in the New York Times, and it shows a doctor that's doing a heart cath procedure. What was interesting about this particular facility, which again was in Elyria, Ohio, was that it sat about 30 miles from the Cleveland Clinic, which is one of the world's most prominent cardiac centers. And what they found when they studied was that Medicare patients in Elyria, Ohio were receiving angioplasties at a rate of 4 times the national average, which made no sense in the world when you had the Cleveland Clinic that wasn't doing nearly as many, was a premier cardiac facility just 30 miles away. Part of it was, again, it was known that the doctors owned the cardiac imaging center, and again, they had incentives to do more tests. Sorry for the interruption. So the second form of payment model that we talked about is capitation, where providers receive a fixed amount of dollars each month to provide care for patients. So essentially this is called per member per month payment. You get a fixed fee per month to take care of a panel of patients. Each patient receives a per member per month payment, but the payment is not tied to the number of services that you provide. So you don't get paid more for doing more stuff. So it eliminates some of the incentives to do unnecessary testing, which may drive up healthcare cost. There's also the concept of the preferred provider organization, also similar for point of service plans, where essentially a person signs up for health insurance under a PPO, preferred provider organization, and a limited number of clinicians who have agreed to accept a lower payment to be in the network are on the list of providers that the patient can go to receive care. The patient knows when they sign up with one of these PPO plans that if they go out of network for their care, they'll have to pay more for care. If they stay within the network, they keep their premiums low. And the preferred providers, they tend to sign up because they get a larger volume of patients, even though they get slightly less payment per patient to be a part of the preferred provider network. Okay, so what if you're not eligible for one of the government-sponsored health insurance plans, like Medicare or Medicaid, or an employment-based plan? Well, the Affordable Care Act that was passed in 2010 did set up something called health insurance exchanges that are state-level insurance exchanges that allow you to buy health insurance at a reduced fee. Some of the coverage is subsidized by the federal government, and there are different levels of plans that individuals can sign up for. Some of you have probably heard that some of these health insurance exchange plans have very, very high deductibles. So it does make it difficult for some people to actually receive care because the deductibles are high enough that they can keep the cost of the premium lower, but to actually receive care, the deductibles are very expensive. So I like this graphic because it kind of shows you in 2019 all the sources of healthcare, remembering that the United States population is somewhere around 330 million people. 59 million people are on Medicare. Your textbook said that we would soon get to 60 million, and we're almost there. This was in 2019. Non-institutional under 65 patients, that's a large group. 273 million people, and then around 12 million people in the United States receive military benefits. Of that large group of people who aren't eligible for Medicare, they're below the age of Medicare, or they're not disabled or on dialysis, that 273 million, the biggest group of them receive health insurance through their employer. Employer-based health insurance, 159 million. 84 million have other sources of coverage. And then there are, in the United States, are about 30 million people who are uninsured completely. If you look at that other coverage, Medicaid and CHIP, 57 million, ACA plans, 13 and 9 million patients that are in ACA plans, and then some miscellaneous others that are a part of the program. So this gives you a sense of where the United States population gets most of its health care. Again, remembering that there are 30 million people in the United States that remain uninsured. Well, what's the consequences of being uninsured or underinsured? If you don't realize it, prior to the passage of the Affordable Care Act in the United States, 15% of the U.S. population was uninsured, and another 7.5% were at risk of bankruptcy because they were underinsured. They had insurance, but it wasn't good enough to cover most of their expenses. And in fact, at that time, medical expenses turned out to be one of the most common causes of bankruptcy in the United States. A patient would have a catastrophic illness, go into the healthcare system, get these enormous bills that they could not pay, and would have to file for bankruptcy protection because of their high medical expenses. So it was very, very common as a cause of bankruptcy in the United States. With the passage of the Affordable Care Act, the proportion of the population that is uninsured in the United States dropped below 10%. So it was a substantial number of people that did get health insurance, but that was variable by state because remember, each state had to decide whether or not they would expand Medicaid or not. Oklahoma happens to be one of the states who did not expand Medicaid, and Oklahoma, I believe, has the second highest rate of uninsurance in the United States. Under the Affordable Care Act, these are the things that any Affordable Care Act health plan has to cover: ambulatory services, ER services, hospitalization, maternity and newborn care. It turns out that that's incredibly important because if we don't cover maternity care, we end up with babies that are incredibly expensive if they need to be in neonatal intensive care unit. Of course, mental health and substance abuse coverage, prescription drugs, rehab services, laboratory testing, preventive and wellness services, chronic disease management, and pediatric services. These are all required as essential benefits under an Affordable Care Act sponsored health plan. So who are the uninsured then in the United States? Well, they fall into three broad groups. The first are the healthy young people like you all who choose not to purchase insurance through their employer. And typically young people feel like they're somewhat invincible. They don't see the need to necessarily carry health insurance. And so they just simply choose not to purchase the insurance through their employer, which may save them some money by not having that deduction from their paycheck. Then there's this large group that are poor to near poor individuals. They don't qualify for Medicaid. They may be at 140% of the federal poverty limit, so they don't qualify for Medicaid programs, and yet they're poor. They can't afford to go out and buy health insurance on the open market. And then there are the group of patients who are self-employed persons. They're employees of small companies. They're patients like Jesus and Olivia that I started my presentation off with, who work, both of them work, but they both work for companies that don't provide health insurance benefits. The other possibility is some self-employed persons simply elect not to purchase insurance because of the cost. Health insurance premiums are quite high in the United States, and they simply decide not to purchase those benefits. A couple of things from the Affordable Care Act most of you are aware of. Children can stay on their parents' health insurance until the age of 26, and then young people between the ages of 27 until the age of 30 can purchase some limited policies. States, remember, each had the opportunity to decide whether or not they wanted to expand eligibility for Medicaid. The benefits of doing that is that the federal match for expansion of Medicaid was 90%, but the state did have to pick up 10% of the cost. So one of the arguments for expansion of Medicaid is that the tax dollars that we pay that are going that would have been used for expansion of Medicaid in Oklahoma go to other states that did decide to expand Medicaid. It allowed people to purchase health coverage through a health insurance exchange. And then, as many of you will remember, one of the reasons that the number of people went up who had health insurance is that there were penalties through the tax code for failure to purchase health insurance, which was also called the individual mandate. That was struck down by the Supreme Court. However, and now the number of insured individuals under the Affordable Care Act has actually started to slip off again. So this map shows uninsurance rates. The state with the highest rate of uninsurance in the country is Texas, followed closely by Oklahoma. Nearly 15% of Oklahoma's population has no health insurance. I've mentioned before that somewhere around 140,000 people just in Oklahoma County do not have health insurance. So we have large populations of patients who are uninsured and rely on safety net and emergency department for most of their care. But you can see the states that have very, very low rates of uninsurance, such as Iowa and Minnesota, Vermont, where rates of uninsurance are less than 5%. This is the same data broken down by county. Again, you can see most of Oklahoma has a fairly substantial percent uninsured by county, with areas that are very, very high in parts of the state. And it varies widely across the entire country. There are other programs for the disabled and the injured that I'll just mention. Workers' compensation for on-the-job injuries, which covers the healthcare costs associated with job injuries. Social Security disability, so if a person has worked, they're eligible for Social Security and they've had some major injury that results in disability, they can receive disability insurance. And then simple Social Security, if for some reason you have can't work and you get the Social Security income that can help you cover your health care costs. I'm going to end this segment of the presentation by simply talking about some of the consequences of not having insurance. And there are multiple studies that document this very well. Uninsured people don't get preventive care services, so therefore they're typically diagnosed with diseases at more advanced stages. So I've seen a number of patients over my career who were uninsured, I particularly remember a female patient who knew she had a lump in her breast, and by the time she got insurance, she came in to see me, and she had a large fungating mass that had already ulcerated through the skin because she had simply tried to wait until she had health insurance before she sought care. The other thing is we tend to use the hospital a lot more commonly for the patients who are uninsured because they come in sicker. They haven't had preventive services. They wait until their diabetes is completely out of control or their asthma is so bad that they can't breathe, and we put them in the most expensive side of care that we have, and that's in the hospital setting. We also know that patients who are uninsured don't get primary care services, so they're much, much more likely to use the emergency department. And if you're not aware, you must remember that under a law called EMTALA, hospitals, any hospital that accepts payment from Medicare must, by law, provide care to any patient who arrives in its emergency department for treatment, regardless of the patient's citizenship, legal status in the United States, or the ability to pay for services. So I've had some colleagues say, well, we have universal health care in the United States because all you have to do is go to the emergency room. Yeah, that's true. They don't have to keep you, but they have to treat you in the emergency room. And remember, hospitals by law may not turn down patients for care if they accept Medicare payment at all. And finally, there have been multiple studies, particularly in the last year, several published in Health Affairs, that have shown that uninsured patients have higher mortality rates and poorer health outcomes than patients who have insurance. Well, I started off the presentation saying we spend a ton of money on healthcare, and just to put it in perspective, I asked the question, how many dollars would it take to get to the moon? Well, it turns out that the moon is on average 384,000 kilometers from Earth. That's 384 million meters or 384 billion millimeters. Assuming the thickness of a US dollar is about 1 millimeter, that means you could stack $384 billion to the moon. But remember, we spend $3.6 trillion on healthcare in the United States. So if you could stack $1 bills, you could stack bills to the moon 9 times. And that's more times than NASA actually landed on the moon. We spend this enormous sum of money on healthcare in the United States. And honestly, we don't get that great of outcomes for all of the dollars that we spend. And we'll talk more about that in the next session. If you have questions, don't hesitate to email me. And again, I'll do one more session, which would be the week 12 session. Then on the week 13 session, I will do a Zoom live session at the usual class time. You don't have to attend, but if you have questions or want to interact about any of the issues in these 2 presentations, I'll be happy to do so at that time. Thank you.